Now, part 3, you're gonna address those weaknesses. In other words, what wasn't in the policy and what should be in the policy based on those. You know, if the evidence base said you should have this and it wasn't in the policy, then your recommendation would be put it in the policy. So, my goal, this seems like busy work for you, but I think many of you will go on to get your bachelor's. You will have to do this. And I want you to be able to see what a completed paper will be like. And at least you will have one that you will, have gotten through. Because if you go after your bachelor's, without a doubt, you're gonna be doing many of these. And so I want you to at least be familiar with the process. It seems like busy work, but in reality, what the ultimate goal is that we can't do things just because we want to do them, or just because it's always been done that way. We have to have evidence as to why we're doing something. And I mean, I'm probably one of the first people who just says, let's do it that way. I don't want to change. But that's not the way of the future. So, and believe me, if some of you are struggling a little bit, and your peers in the hospital would as well. It's kind of a new concept, even though we've always talked about it, to actually bring it into reality is a new concept. And so, from a conceptual standpoint, it's hard for everyone. So, but I want you to have one successful experience with it, so that if you do go on, you'll know what the expectations will be.
And are you still considering doing a review for the next test in management? Like even just a little bit of time after our lectures?
I was going to tape, and I think I have not taped yet.
Okay, but you're thinking about.
I will basically, I think I said I was gonna go to the chapters underneath. So like, I can't remember, is it learning plan 3, 4, and 5?
Yeah.
So like on 3, what I'll probably do is take the chapters that are involved in learning plan 3 and just sort of review those chapters briefly. And then same thing for learning plan 4, and same thing for learning plan 5. So probably 3.
Okay, that'd be a huge one.
Okay, moving on to upper GI problems. Now, first we're gonna talk briefly about nausea and vomiting. Obviously, one of the most common disorders in the GI tract. And it also can occur in many other systems. People get pregnant and they have GI symptoms. People get cancer, they have GI symptoms. You get an infection, you have GI symptoms. So a lot of systems have similar problems with nausea and vomiting. Basically what happens with nausea and vomiting, stimulus is involved in the act of vomiting. The vomit center is in the brain stem. And basically it involves neural impulses through the autonomic nervous system. There's chemoreceptors that a trigger zone in the brainstem that will respond and then send impulses to the vomit center. And it can happen quickly or it can develop slowly. Basically with the sympathetic nervous system, which increases, you can get tachycardia, tachypnea, diaphoresis accompanying that. If in the parasympathetic nervous system, when your lower esophageal sphincter relaxes, and there can be increased motility in the GI tract, and also increased salivation, which can accompany nausea and vomiting. So clinical manifestations, obviously nausea is quite subjective, and typically vomiting is considered a forceful ejection of usually partially digested food. Regurgitation is partially digested food that comes up from the stomach. And then projectile vomiting is forceful expulsion of the stomach, but you usually, nausea usually does not accompany projectile vomiting. And projectile vomiting is indicative of brain injury or head injury and also of CNS tumors, where they will have projectile vomiting without nausea. Also, anorexia is common. Remember that anorexia can lead to dehydration and electrolyte imbalances. Patients can develop metabolic acidosis and alkalosis from vomiting. They can have fluid loss. As they're vomiting, it increases the risk for aspiration. Also, emesis can occur after meals. That can be related to the gastric outlet. It can be an obstruction disorder, or they can have problems with gastric emptying or stomach emptying. If a patient has sort of a fecal odor to their vomit, that can indicate that there is an intestinal obstruction. Also, if there is blood in the emesis, or if it is coffee ground, that can indicate that it was in contact with the stomach contents. Bright red indicates that it is active bleeding. It could be related to what is called a Mallory-Weiss tear, which is when you are vomiting so hard that you actually tear the esophagus, and that usually comes with severe retching. Typically, drug therapy will depend on the cause of the nausea, but antiemetics are used. Promethazine is a common one that we give IM. It has some side effects, Compazine does. Also, we can give Reglan or metoclopramide, metoclopramide, which is Reglan. Also, we can give serotonin receptor antagonists, as well as dexamethasone, which is oftentimes used for chemotherapy or nausea. Also, Zofran or ondansetron is oftentimes given post-op or in pregnancy. Nutritional therapy is also important with nausea and vomiting. IV fluids and lights are important. Water is important. And non-drug therapy for nausea and vomiting can include things like acupressure, acupuncture, as well as herbs. We all know that ginger and peppermint, a lot of restaurants give us peppermint candies after a dinner. That is helpful. Relaxation and breathing can be helpful for nausea and vomiting as well. Now, when we look at or assessing nausea and vomiting, we obviously want to identify patients at risk. A patient going for a jaw wiring is, you want to anticipate that you will have antiemetics on hand when he comes back from surgery. You don't want him vomiting, although it is safe to vomit, but there is a lot of fear that is involved with that. So, you just instruct them to get their head dependent. Vomitus can come from, over the teeth in the back, and they usually can safely throw up, but it's a scary thing if your jaws are wired. So anticipate that you would want to give them an progress with it. Typically, our overall goals would be to minimize or diminish the nausea and vomiting. You want, from a lab standpoint, for them to have normal electrolytes, and you want them to have normal I&O. Until they are diagnosed, if a patient is having a significant amount of nausea and vomiting, obviously you would want to get them NPO. You want to make sure that you have IV access so that they will be getting fluids IV to maintain fluid and electrolyte balance. Then you would probably consider putting down an NG if you need to decompress the stomach. Then you'd probably give antiemetics. And remember that a patient who has nausea and vomiting is going to have a sour tasting mouth. So you want to make sure that you give oral care. It's something that we don't always think about. But make sure that they have IV access if they're not able to get in food and fluids. From a gerontologic standpoint, obviously we have to carefully assess and monitor. Remember that the elderly are at risk for fluid and electrolyte imbalance. We can overhydrate them. We don't want to put them into circulatory overload. They're more likely to have cardiovascular or renal insufficiency, and that will increase their risk for fluid and electrolyte imbalance. Also, because they have drier mouths and problems with dysphagia, they're at increased risk for aspiration. Also, if they have a decreased level of consciousness, they're increased risk for aspiration. They are particularly susceptible to CNS side effects of antiemetics. Remember that they have less tolerance for drugs. The renal or the kidneys cannot absorb drugs the same way that other adults. So they're at increased risk for confusion, as well as confusion increases their risk for falls, so significant. So generally with drugs, we will reduce their dosages and implement safety precautions for them. Now, oral inflammation and infections are usually due to oral diseases, or it can be related to systemic problems such as leukemia or vitamin deficiencies. But it can impair oral ingestion. Also, patients who are immunocompromised or who are on corticosteroids are at increased risk for inflammation of the mouth. They can develop gingivitis. They can develop oral candidiasis, also patients on multiple antibiotics. Herpes is a concern. Stomatitis and parotitis are all inflammations that can be a concern. So regular, good oral and dental hygiene is important. It is important to identify the cause. If it is infection, to eliminate that, and obviously you want to provide them with comfort measures, and more importantly, maintain their nutrition. Oral cancer, basically there's two types, oral cavity cancer and then also oral pharyngeal cancer. Typically, squamous cell affects the head and neck. They really don't know what causes oral cancer. However, smoking has been implicated. Tobacco, also frequent drinking, and prolonged exposure to sunlight can also cause lip cancer and other types of cancer. And also the human papillomavirus, or HPV, has been associated with oral cancer, and having multiple sex partners will increase that risk. Here are types and characteristics of oral cancer: lip, tongue, and oral cavity, and then typical manifestations and treatments for that. When we think of diagnostic studies, a lot of studies are cytology, or cell studies. A toluidine blue test can be done to diagnose the type of cell. Once they have a cancer diagnosis, then usually they will do like CTs, MRIs, PET scans, etc., in order to stage the cancer and determine the type of treatment. Oral cancer, usually they will do an H&P biopsy, the cytology, toluidine blue test, and then collaborative therapy will be dependent, again, on the staging and recommendations from the surgeon. Oftentimes it involves, though, a radical neck dissection, and that can be significant. It can involve removal of the trach and of the voice box, for example. And so those patients will be at risk for fluid and volume imbalance, and oftentimes require energy tubes. Non-surgical therapy includes chemotherapy and radiation. Oftentimes they will use 5-FU, which is a chemo drug, methotrexate. They can also use brachytherapy, where they put a seed in and implant. They also will do palliative care. Again, G-tubes, not through the oral, but they actually have to put a G-tube in order for them to get nutrients. Obviously, suctioning is going to be a concern. And analgesia will also be important to provide for oral cancer. Subjectively, obviously we want to get their health history, find out what kinds of meds they're on, what surgery have they had. Objectively, we look at their integument, we want to look at their GI tract and what diagnosis they've had. Obviously, with any treatment, our significant concern would be their airway, because it's in and around their mouth. Communication, we want to make sure that they have a method to communicate if we are blocking or removing their voice. Adequate nutrition is necessary to heal. Patients with radical necks can have significant drainage. And so they require increased calories. And obviously relief of pain is a concern as well. The most important thing for promotion is early detection and treatment, and especially identifying those patients who are at risk for oral cancer, including tobacco, smoking, chewing, drinking, etc. Esophageal disorders, GERD is probably the most common problem. With GERD, you have mucosal damage. GERD is not a disease, it's more of a syndrome. And pathologically, it's caused by reflux of the gastric contents into the lower portion of the esophagus. But there really is no single cause for it. There are some predisposing factors, such as a hiatal hernia can cause GERD, as can a dysfunctional lower esophageal sphincter, and if there is inadequate esophageal clearance, or if there's decreased gastric emptying. All of those can predispose one to GERD. Risk factors include obesity, as well as pregnancy. A lot of pregnant women develop GERD. Smoking and also a hiatal hernia plays also a role. So here we have a picture of reflux disease with the development of some ulcerations or esophagitis, which is inflammation of the esophagus. And with esophagitis, we develop scar tissue, which can cause strictures and dysphagia, which is a common complaint of patients with GERD. So clinical manifestations, heartburn is probably the primary symptom, which is usually defined as sort of a burning sensation. And usually to be diagnosed with GERD, it has to occur at least 2 times a week. They may have dyspepsia, regurgitation. They may have respiratory symptoms, a frequent cough, maybe wheezing, dyspnea. They may have a nocturnal cough that occurs because when they're laying back, that lower esophageal sphincter relaxes and the reflux, and that comes back into their esophagus and causes a cough. They may be hoarse or develop a sore throat. They can develop chest pain that can mimic heart problems. They may develop burning, squeezing. It can radiate almost like angina. But it is relieved with acids, and that's usually the way they'll distinguish cardiac from GERD. Esophagitis, again, is related to that continuous gastric contents that falls on the mucosa and causes inflammation. We have something called Barrett's esophagus, where there is esophageal metaplasia or changes in the cellular composure of the esophagus. Barrett's esophagus is considered a precancerous disorder. And usually, if someone is diagnosed with Barrett's, they recommend scoping them every 2 to 3 years to monitor it so that it does not become cancerous. Respiratory problems, again, cough. They may develop bronchospasm or laryngeal spasm. And dental erosion. When you're getting gastric contents reflux, you can develop dental erosion. It can wear off the enamel from your teeth. One of the possible treatments is what is called a GERD or a Nissen fundoplication. It's down here, Nissen fundoplication. Basically, they close off a portion, they remove a portion, suture that, and the fundus is wrapped around the distal esophagus and then sutured onto itself. And that is one of the measures that is done for GERD. Also, they can do diagnostic studies such as endoscopic studies, and they can do go down with scopes. They also can do cryotherapy with cold, and they can do ablation with lasers. And there are a number of other measures that they can do. They have something called the LYNX reflux management system. It involves placing beads that are implanted actually into the lower esophageal sphincter, and it helps the function of that. If a patient has a LYNX procedure, they would no longer be able to go in for MRIs because it is sort of a metal thing that, you know, in the magnet of the MRI, it could displace. With regard to also barium swallows can be done as far as other diagnostics. They can do cytologies, they can do motility studies. They also check pH. Now, as far as collaborative care, you want to avoid triggers, so lifestyle modifications, change the diet. You want to change drugs. There can be drugs that can cause GERD. Nutritionally, you usually decrease fat, and you want to encourage fluids between meals, not with meals. Discourage milk at bedtime because milk can kind of cause sort of a mucousy secretion. And also, they're encouraged not to take late snacks because, again, when they're laying, it can cause problems. Avoid chocolate. Orange juice also decreases LES or lower esophageal sphincter. Decreasing weight. Chewing gum and throat lozenges actually does help. And increasing saliva, so you can buy some of those saliva, Biotine, will actually increase saliva, and that is helpful as well. Drug therapy, anytime a patient is having heartburn, a lot of times they will order PPIs or proton pump inhibitors. Patients need to be taught about proton pump inhibitors. Also, H2 blockers. It does increase the risk for C. difficile, and that is sort of a recent finding. So there are patients on PPIs and H2 blockers who have to be taken off or put on a different medication in order to decrease the risk for C. difficile. If a patient develops C. difficile from their PPI or H2 blocker, they have to go into contact isolation because C. difficile is contact spreadable. Also, you would want to check their blood pressure and their heart rate. And obviously, you would want to let the physician know what is going on. Typically, for general complaints of discomfort, they will give them just Tylenol. In addition to PPIs and H2 blockers, they also can give acid protection meds such as sucralfate, that pink stuff. They can give cholinergics such as urcoline. They also can give prokinetics. Reglan is, or metoclopramide is a, which is Reglan, is a prokinetic. And then, of course, antacids. Surgical therapy, we already talked about that. Nissen fundoplication can be done, as well as a Lynx procedure. And this just shows the normal esophagus. Remember too, hiatal hernia is a risk factor. So a hiatal hernia does increase the risk for GERD. And again, endoscopic therapy, including that Lynx procedure, and along with cryotherapy, etc. Now, nursing management, obviously drugs are a significant part, but keeping the head of the bed up at least 30 degrees, encouraging them to stay upright after meals. They really shouldn't lay down for about 2 to 3 hours after they eat. Again, no late night eating. You want to avoid factors that increase reflux, so no smoking, drinking, caffeine, any acidic foods. Reducing stress is significant. Weight reduction, small frequent meals. Also, if they do have a fundoplication, You need to prevent respiratory complications, fluid and electrolyte imbalances. Remember that now the stomach is wrapped around that lower esophagus. They're at increased risk for infection, so you want to watch for that. Usually after a fundoplication, they may have swallowing difficulties for about a month after. That's not unusual. Remember that if they're on antacids, because they contain aluminum, that it can cause constipation. Also, if it can contain, antacids can contain magnesium. If they get too much, that can cause diarrhea. Hiatal hernia, if we slip back to that one picture, there are types of hiatal hernias. There's a sliding which will move up and down. Basically, the stomach slides through the hiatus or the opening when they're supine, and then it moves back when they're upright, so it slides. It's probably the most common type of hiatal hernia. You also can develop a paraesophageal hernia or a rolling hernia, and that basically is when the fundus of the stomach sort of rolls through the diaphragm. It is a medical emergency because it can strangulate that hernia. So you want to be aware of those types of things. Mostly it occurs in older adults and in women. And here is, again, possible sites for esophageal diverticula. And diverticula is, as you would see in the GI, colon and the small intestine, you have these outpouchings. Zenker's diverticulum is actually in the esophagus. It's the most common type of diverticulum in the esophagus, and you can actually see a pulsation with the Zenker's diverticulum. So, manifestations with hiatal hernia, it can be asymptomatic, but a lot of the symptoms are like with GERD. They can have heartburn after meals, dysphagia. When they bend down, they might have increased pain, but when they sit up or stand, it decreases because if it's a sliding hernia, it changes. Also, taking in large meals can cause signs and symptoms, as can drinking and smoking. Complications of hiatal hernia include GERD. They can develop a strangulated hernia, and that is, again, a medical emergency. They can develop regurgitation, respiratory problems, as well as stenosis, and also hemorrhage. Hernias can hemorrhage. Typically, to diagnose, we can do a barium swallow or an esophagram. We can do endoscopy to see the lower esophagus, and that will also show us if there is esophagitis or inflammation. Conservative treatment for hiatal hernia usually is lifestyle changes or modifications, similar to what we would do for GERD. Encourage them not to smoke, encourage them not to drink, to lose weight, etc. Surgically, they can reduce hernias. They can do a herniotomy, which is simply a excision of the hernia sac itself. They can do a herniorrhaphy, which is closure of the hiatal defect, closure of that area where it is moving up and down. They also can do what is called an anti-reflux procedure, It is again, a laparoscopic procedure. They can do a Nissen fundification. And obviously the goals are to reduce that hernia, and to, get that lower esophageal pressure back into a normal range, so that they don't have signs and symptoms typical of, hernia and of, GERD. With regard to, the elderly, they are at increased risk, and incidence, both of these, GERD and hiatal hernia. And usually it's associated with weakening of their diaphragm. They have general musculature changes. Also, they develop kyphosis, so it puts increased pressure and intra-abdominal pressure. Meds that are taken by the elderly can actually decrease the lower esophageal pressure, such as nitrates, calcium channel blockers, and antidepressants all can cause problems, GERD type problems. The first indication that there might be esophageal bleeding, oftentimes is respiratory complications. A typical patient will come in and say they're on NSAIDs. NSAIDs can cause esophageal bleeding. Also, potassium can be, if it's not swallowed with adequate water and it sits in the esophagus, it can also cause problems. So lifestyle changes, discussion of their beds, etc. is helpful. Esophageal cancer, obviously, it is a neoplasm of the esophagus. It's not real common. More males have it than females, and usually it is squamous cell squamous cell adenocarcinoma. Risk factors, probably the most frequent, smoking and drinking. Also, remember we talked about Barrett's esophagitis. It should be followed every 2 to 3 years to make sure it's not turning into esophageal cancer. Also, if a patient has a history of achalasia, achalasia is when there's delayed emptying of the lower esophagus. Food just kind of sits there, that bolus sits there, and it doesn't empty as rapidly. So peristalsis is not moving it through the lower GI tract. Typically, the symptoms show up late, and they will develop progressive dysphagia, especially with meat. Pain is kind of a late sign and symptom. They may have weight loss. They may cough up blood, but again, that's kind of a late symptom. But they may more frequently complain of sore throat, maybe choking, hoarse voice, etc. Typically, complications that can occur, bleeding is probably the most important one. They can develop fistulas or obstructions. And of course, if they have cancer in the esophagus, they can develop metastasis. It can go to the brain, it can go to the lungs, to the liver, etc. Diagnostically, again, we can do endoscopic biopsies and ultrasounds. We can do bronchoscopes, CTs, MRIs, etc. Treatment is dependent on the location and the type. Esophageal cancer kind of has a poor prognosis. Treatment is best when it's given as a combination treatment. Surgery includes an esophagectomy, which removes a portion of the esophagus, an esophageal gastrostomy, is when they will anastomose or bring the esophagus together with the stomach. It shortens the esophagus, but it does still allow passage of food. They can do a number of, they can even attach the esophagus to the intestine if need be. So there are ways that they can deal with esophageal cancer. Radiation and chemotherapy is oftentimes done concurrently with surgery. Nutritional therapy, obviously they'll probably need parenteral nutrition after surgery. They may require palliative care in order to restore their swallow. They may have to dilate the esophagus. Typically they will have swallow studies to make sure that they are able to take in food and fluids without problem. So you obviously past history, again, do they have a history of GERD? Maybe they have a hiatal hernia. Maybe they have had that delayed emptying with achalasia. Are they smokers? Are they drinkers? Have they had heartburn? Are they hoarse? Do they have a cough? Do they have anorexia? All of those kinds of things. Typically, what we want to do is relieve the symptoms. We want optimal independence for them and optimal food and nutrition. And we want them to have as good a quality of life. Again, remember the prognosis is not the best. So we want to get as good a quality of life as that cancer progresses. Health promotion, obviously, encourage no smoking, drinking, etc. With regard to post-op care, it is important that after they've had the surgery that you check for swallowability, for drainage. Remember they are at risk for bleeding. They'll probably have a G-tube, so whatever is involved with that care. Incentive spirometry will be important because they'll be at risk for respiratory problems. Usually they're placed in a Fowler's position with the head of the bed up. So normal post-op cares beyond what is specific for esophageal. Now, upper GI or GI bleed is increasing in women, particularly associated with NSAIDs. It's the most, we have a serious loss of blood from the upper GI tract with upper GI bleeding. It's usually sudden onset. The seriousness of it depends on its origin, whether or not the bleeding is occurring in the veins or in the capillaries or in the arteries. Obviously, if it's arterial bleeding, you're going to have profuse bleeding. Usually it is bright red, which indicates it's not been in the stomach. A massive GI bleed is when there's over 1,500 cc's. And remember that a blood or a loss of blood volume that much can put them into hypovolemic shock. There are various types of GI bleed. Obvious bleeding can include hematemesis, having vomitus that includes blood. Also, there can be melena or blood in the stool. Then there can be occult blood, where the blood is obviously not seen. So we see here manifestations, hematemesis, melena, black tarry stools, often foul smelling, and a guaiac test is done for occult bleeding. Now, with regard to the common causes of upper GI bleed, probably the most common sites for GI bleed are the esophagus, the stomach, and the duodenum. And in the esophagus, oftentimes they will have GERD, and drugs are responsible. Aspirin, NSAIDs, and steroids also. They might be smokers and drinkers. With regard to stomach and duodenal origin, oftentimes bleeding is related to peptic ulcers, and that's related to H. pylori. Also, it could be due to aspirin or NSAIDs. It could be related to cancer, GI or stomach cancer. Polyps and stress ulcers can also cause bleeding. So drug-induced origin can be a factor, as can systemic disease origins as factors. But oftentimes it is related to drugs. Also, stress-induced ulcers are typically, we have to watch patients who come in with major trauma. They are at increased risk for stress ulcers. And so we automatically put them on anti-ulcer drugs when they're in the intensive care, because we anticipate they will develop stress ulcers. So oftentimes we put them on famotidine or Pepcid to inhibit the development of stress ulcers. This is factors that are involved in GERD and the dysfunction of the lower esophageal sphincter. Emergency treatment, then collaborative care with regard to GI bleeds. Obviously H&P, but you need to delay that if they have significant bleeding. You are going to watch for signs and symptoms of shock and treat it accordingly, usually IV fluids. We need to check an abdominal exam, check for bowel sounds. The belly may be tense and rigid. If it has perforated, they may develop peritonitis. Also, when we have a GI bleed, we want to make sure we have 2 IVs with big bore needles, with the idea that we may have to give blood. Obviously, we have to check their religious status. Remember, Jehovah's Witnesses may not take blood. On the other hand, they may take crystalloids or a volume expander that could be given in the event of bleeding. Always check urinary output. A patient who's a GI bleed is going to have a catheter. Usually a CVP line is placed so that we can monitor their fluid status. And with a GI bleed, it would be important to document what is happening, the events that not only led up to the bleeding, but then the measures that you are taking in order to deal with it. Oxygen is necessary. With a huge blood volume loss, that's significant. PPIs are given, and they may have to be given by endoscope to prevent stress ulcers. They may have to go down with an endoscope in order to do an ablation or stop the bleeding. They may use heat, a laser, in order to stop it, or they can use cryotherapy or electrocautery. Surgical therapy would be indicated if even after they've gotten whole blood, they are still exhibiting signs of shock. And then, of course, any of the major drugs that we are given in an emergency, that would be significant. So a GI bleed is an emergent condition. Diagnostically, we would do endoscopes. We might do angiographies as well as get labs. Obviously, hemoglobin, CBC. Remember that of GI bleeds, about 80 to 85% of them will stop spontaneously. However, we can't allow their hemoglobin and hematocrit to drop while we're waiting for that to happen. So we do have to treat them. Endoscopic therapy is usually the first line of management. They will go down with an endoscope. Surgical therapy, again, if they are still bleeding after they've been given 2,000 cc's of whole blood, or if they have been in a shock condition for 24 hours, that would be significant. Drugs are given to decrease bleeding, to decrease the hydrochloric acid, and to neutralize that. Usually the drugs that are given are epinephrine, H2 receptor blockers, as well as PPIs or acid reducers, and also somatostatin. And what that does is it decreases flow to the GI organs, and it decreases acid secretions. Sometimes patients who have GI bleed will excrete that blood in their stool. If a patient is having bloody diarrhea, always get a stool culture, so you want to find out what is going on there as well. They may also be having hematemesis, and a lot of times that is cultured as well. Other esophageal disorders, such as diverticula, we saw already those outcome things. Typically, symptoms are dysphagia, regurgitation, coughing. They may have problems with aspiration. Complications of diverticula can include malnutrition, aspiration, and perforation. There really isn't a specific treatment for esophageal diverticula. Again, we just monitor them. This is esophageal achalasia, where there's that delayed emptying in the lower esophageal sphincter. There also can be some torquing or twisting that can cause problems as well. Esophageal strictures can cause GERD. Oftentimes, those are treated with dilatation endoscopically. Again, achalasia, no peristalsis or delayed emptying in that lower esophageal sphincter. Usually it comes on insidiously. Again, they may complain of dysphagia. They also may have halitosis because the food sits there and doesn't empty. Remember, halitosis is foul breath. And oftentimes they will diagnose achalasia with a barium swallow. Pneumatic dilatation can again treat achalasia by dilating and decreasing that LES sphincter tone. This shows stress ulcers within the stomach, highlighted by dark digested food. Again, remember, stress ulcers are usually concerned with head injuries also, stress ulcers, but major trauma, almost all the ICU patients are treated prophylactically against stress ulcers. Esophageal varices, is when there is just like varicose veins, but in the esophagus. And it's usually a result of liver hypertension or portal hypertension. And it's a common complication of cirrhosis of the liver. So when we are assessing, again, this is flipping back and forth to some strange things. Going back to GI bleed, I think we already talked about that enough. Remember that it is, even though there is a spontaneous stoppage of bleeding, there are times when significant measures have to be taken. And that's also GI bleed. Okay, disorders of the stomach and the upper small intestine. Gastritis basically is an inflammation of the gastric mucosa. It's pretty common. It affects the stomach. Basically, that mucosa breaks down. Risk factors can include drugs, diet, and H. pylori. With regard to autoimmune gastritis, there is something called atrophic gastritis. It's inherited. It is a loss of the parietal cells. Remember, I talked about those 4 types of cells that secrete. Here, remember the parietal cells are active in, they can cause, when you lose parietal cells, you have low chloride, you have a decrease in your intrinsic factor, and so you have cobalamin or B12 malabsorption, and you can develop pernicious anemia. The treatment for atrophic gastritis is cobalamin injections, and by getting those injections, it helps to prevent the patient from becoming anemic. So patient's history of drug, alcohol use, all of those are important. Usually endoscopically, they will do a biopsy. They will check for H. pylori infection and do a CBC to check their hemoglobin for anemia. Acute gastritis, obviously, you want to eliminate the causes of these. Symptoms of acute gastritis include anorexia, nausea and vomiting. You can develop epigastric tenderness, and oftentimes patients with acute gastritis have a sensation of feeling full. Chronic gastritis is just that. It becomes chronic, but symptoms can be ongoing, and supportive treatment is usually what is given. Symptoms are similar to acute gastritis with the anorexia, tenderness, etc. Peptic ulcer disease then, there are types such as, and we call peptic ulcer disease PUD, PUD. Basically, there is erosion of the gastric mucosa. An acute peptic ulcer usually is of short duration. A chronic, obviously longer. You can develop gastric peptic ulcers, those that are in the stomach, or duodenal peptic ulcers, those that are in the small intestine. So peptic ulcer disease is when the area erodes. There can be bleeding, and obviously it's going to cause pain. Here is a peptic ulcer in the duodenum, or the portion of the small intestine. So peptic ulcer disease, basically it develops in an acidic environment. And so the pathophysiology of it is there's disruption of the gastric mucosa, and the consequences of back diffusion as of those acids. So those acids then are immobile and they burn into the mucosa and cause openings. With regard to the relationship between mucosal blood flow and disruption of the gastric mucosal barrier, we see that there is barrier disruption, acid back diffusion, which results in injury. Now, if they have significant ulcers, it can even cause shock and tissue anoxia along with acidosis. So it's not a simple thing. So Heliobacter or H. pylori, this is something that you can get colonized. About 2/3 of us, even in the world, are colonized with H. pylori. The question is, does it get out of hand? Also, medications can cause peptic ulcer disease, such as aspirin and NSAIDs and corticosteroids. Those are probably the 3 most common. Drinking, smoking, coffee, stress can all cause problems. Gastric ulcers typically are found in the antrum of the stomach, usually in females, and as we age, we have an increased risk for gastric ulcers. Gastric ulcers puts us at risk for obstruction then as well, because there's scarring and then movement of the food bolus cannot occur. Duodenal ulcers affect the small intestine, and typically it affects men and women 35 to 45 years of age. So it most typically younger folks will get duodenal ulcers. And then stress-related mucosal disease. Now, gastric ulcers, usually, again, they will have pain high in the epigastrum. They usually will get pain about an hour or 2 after they eat. It's sort of a burning pain, and food aggravates the discomfort. In duodenal ulcers, peptic ulcers, usually the pain occurs 2 to 5 hours after a meal, so it takes longer. They also can have burning pain, but oftentimes it goes to the back and the mid-epigastric area. Gastric ulcers are usually a little bit higher. Complications can include hemorrhage and perforation, as well as obstruction, gastric outlet obstruction. And here is a peptic ulcer or a duodenal ulcer that is penetrating into the head of the pancreas, so that could be very painful. With regard to additional complications, remember that obstruction is another one, along with hemorrhage and perforation. Typically, endoscopic studies are the most accurate for peptic ulcer disease. They can do biopsies as well. They can do stool tests to check for bleeding. They also can do blood antibody tests, particularly testing IgG. And they can do a barium contrast to check for obstructions as well. Drug therapy for peptic ulcer can include histamine or H2 receptor blockers, as well as PPIs. Antibiotic therapy would be given for active H. pylori, and then, of course, antacids as well. And remember that antacids with that alum can cause constipation and phosphorus depletion. Calcium can cause constipation or diarrhea and renal calculi. Magnesium can cause diarrhea and hypermagnesemia. And sodium can cause milk alkali if it's used with large amounts of calcium. In addition to drug therapy of the PPIs and whatnot, they can also use cytoprotective drug therapies. That would be something like sucralfate. And usually those are given about 30 minutes before or after antacids. They also, misoprostol is another cytoprotective drug that is given if patients have to be on aspirin or NSAIDs. Other drugs that might be helpful are tricyclic antidepressants as well. Nutritional therapy for peptic ulcer, there's really no specific recommendation, but to eliminate alcohol, and if they can identify a causing nutrition, then to eliminate that. Other therapies are related to complications such as perforation and obstruction, what needs to be done for that. So when we look at a patient with peptic ulcer disease, we want to examine and ask them about the pain, when does it occur, what precedes it, and find out how much they know about it. Teaching might be involved. They may, if they have had healed peptic ulcers, you may find that they are having exacerbation of problems just from stress, and they may not associate that with stress. So lifestyle changes are important with regard to peptic ulcer disease. With regard to health promotion, obviously you want to identify patients that are at significant risk, and then obviously for hemorrhage, perforation, we're going to take those emergency measures that we would do for a GI bleed. Gastric obstruction may involve surgery. It may involve medications for peristalsis to occur. They can do gastroduodenoscopy or Billroth procedures. This is a Billroth procedure. It's basically a partial gastrectomy where they remove the distal 2/3 portion of the stomach, and they anastomose then that gastric stump, or that 1/3 portion of the stomach, to the duodenum, and that helps to get rid of the ulcers. And if it is being caused by H. pylori, it eliminates a large portion of that as well. One of the problems or complications associated with Billroth is that they may not have bowel sounds immediately, so you have to monitor that. Also, they can have bleeding postoperatively, so you want to monitor their blood pressures. Observe if usually they will do an aspirate, and you want to observe what that aspirate looks like. You want to listen to bowel sounds. Bright red drainage into the NG drainage could indicate that they are having a hemorrhage, because they would have an NG tube post-operatively. Again, monitoring their blood pressure and vital signs. Obviously, if you think they're having bleeding, you're going to notify the physician for that purpose. Dumping syndrome is another problem that can occur post-Milroth. Usually it occurs 15 to 20 minutes after a meal, and it's when fluid is drawn into the bowel, and they can get a little lightheaded with that. And they have to get to the bathroom rather quickly. Postprandial hypoglycemia is sort of a variant of the dumping syndrome. They have hyperglycemia, and then it can also have hypoglycemia with that problem. Bile reflux, they can have epigastric distress after meals, and usually vomiting will give them temporary relief. Usually bile reflux gastritis is treated with cholestyramine or Questran. It is an enzyme. So again, post-op, check for aspirate for bleeding, and again, make sure that if it is something new, that you're notifying the physician. With regard to the elderly, obviously there is increased mortality and morbidity, particularly if they have the complications of peptic ulcers such as bleeding and perforation. Be cognizant of the fact that they may not tell you that they're on NSAIDs over the counter. So you really have to ask them point blank if they are taking ibuprofen or naproxen or Motrin or something of that nature. Sometimes the elderly's first symptom of a peptic ulcer is not pain like it is with the younger, but they actually may have frank bleeding, or they may have a decrease in their hematocrit. So, be alert and follow their labs. Make sure that you're teaching them about NSAIDs and the dangers of NSAIDs, and that it is important to take NSAIDs and other irritative meds with food, or milk, or with antacids if there's not a problem with incompatibility of those drugs. That those can help coat those NSAIDs, and they may not develop GI bleed or peptic ulcer disease with that. Stomach cancer, again, an adenocarcinoma, and really it's usually cancer that is autoimmune. It can be from exposure to irritants as well as simple exposure to NSAIDs. NSAIDs are dangerous. Corticosteroids are dangerous if they are taken inappropriately. Tobacco obviously is another causative factor. Typically what we see in stomach cancer is complaint of weight loss. Remember we talked about the loss of 10 pounds over a 6-month period without reason for it could indicate stomach cancer. They may be eating and be filled up very rapidly. Early satiety is typical of stomach cancer. Indigestion and abdominal pain. Also, when you're looking at the labs, they may develop anemia, typical of stomach cancer. Diagnostically, we can do endoscopy, biopsy, cytology. Labs are very helpful. CBCs. We can do UAs and stool cultures. Liver enzymes. Tumor markers are typically done with cancer as well. And then treatment can include surgical therapy, removal of portions of the stomach, Here we have a total gastrectomy. They've removed the entire stomach and then anastomosed the esophagus to the jejunum. Obviously, that is going to play a role in the amount of food that they can take in, and they're going to be at increased risk for fluid and electrolyte imbalance. Surgical resection can be accompanied by chemotherapy and or radiation. And typically we would go through the same assessment and diagnosis nursing process that we would with any type of cancer. Foodborne illnesses and poisoning, E. coli is the most common. Typically, what we see is illness that is related to bacteria that can be from canning, etc. They may actually present with nausea, vomiting, or just bloody emesis. Also, it can result in diarrhea. If they have diarrhea, you do not want to give them Lomotil because it will keep that bacteria in their system. You want to get that out. So you would encourage peristalsis and the E. coli to be eliminated. Okay,